development of educational strategies for evidence-based, culturally competent end-of-life and crisis situations, communication skills for trainees and specialties beyond palliative care. So the project director for this is Jennifer Lacaze. She's the medical director of UHS Adult Palliative Care, Assistant Professor of Medicine, UT Health San Antonio. Veena Prasad, part of Behavioral Health Consultant, Office of GME. Adriana Dyurich, PhD, LPC, Behavioral Health Consultant, Office of GME, UT Health San Antonio. Riom Kwakman, MD, PG3 Surgery Resident, UT Health, San Antonio. And we have no conflict of interest to report. Objectives. The participants here will learn to describe emotional and communication considerations unique to end-of-life discussions and situations with parents and children, and consider importance of cultural and religious aspects of end-of-life care, and educational strategies to teach residents on how to focus on patients' values, goals, and help them advance care planning and for life-sustaining treatment, and use of appropriate elements of informed consent. Also encourage and support residents and clinical faculty to feel confident and competent in providing palliative care in many diverse cultural settings. Provide resources to alleviate emotional exhaustion and burnout that physicians may face by feeling unprepared to have difficult conversations. So the rationale for developing culturally competent communication skills for end-of-life conversations is the COVID-19 pandemic hit us and many were unprepared. And there's no clear strategy to teach residents and fellows how to have effective, culturally competent and compassionate conversations with patients and families about death. And residents and faculty in multiple departments, they express feeling of unpreparedness, and they're very uncomfortable in facilitating end-of-life conversations. Healthcare workers sometimes are left with trauma of having to care for multiple patients and their families at the end of life with little or no training at all. So we propose a consolidated resources to teach and empower residents to have conversations and facilitate difficult situations with comfort and compassion. Multiple evidence-based communication strategies and resources have been developed and implemented in the field of palliative care. Some of them are Vital Talk, Center for Advancement of Palliative Care, CAPC, Prepare for Your Care, 5 Wishes, OSCEs. There's a wide variety of methods for teaching end-of-life communication skills in palliative care, training programs, didactics, role play, and reflection. Still, there remains a need for education and training for healthcare professionals to address end-of-life care, which is situation-specific, specialty-specific, incorporate sensitivity to cultural and spiritual values that is centered around family-centered care, address aspects of care that may be a source of distress for healthcare professionals, provide tools for recognizing, addressing distress when it occurs. There's a need for further training. According to recent reports, burnout, pressing need for more healthcare workers, even suicides, and need to address suffering, distress, and trauma in doctors and other providers, as well as patients. And there's a report of moral injury. So our question is the resident, fellow, or faculty, are they avoiding end-of-life conversations? Are they showing behavioral changes, irritability, crying spells, depersonalization, detachment, lateness, avoidance, or are there complaints from staff and patients? These are some indications that residents, fellows, and faculty there's a need for further training.
Thank you, Dr. Prasad. There's also a clear importance to address cultural considerations, especially in institutions like ours that we serve a diverse population. It's important to take into account culture, religious aspects of end-of-life care, and it's also important to consider social determinants of health. Considering these factors might promote a greater empathy and understanding between the provider and the patient's family, and help diminish some of the distress. It might also help understand and witness emotional responses that sometimes are very closely related to the culture of the patients and their families. Not only is it important to pay attention to cultural considerations when it comes to patients, I would say, based on our experience with our residents and fellows, that is also important, when possible, to create a safe space for or activities that will help residents and fellows understand their own cultural and religious beliefs surrounding an end-of-life healthcare, in even what's going on with the pandemic, because this incongruence that sometimes they're feeling is often a source of distress. And then help them remember that the importance of patient-centric care. This is more of an insight-seeking activity. We still have to take into account the culture and the religious beliefs of the patients before we take into account of the doctors. So as Dr. Prasad was saying, there are resources out there that might help with these communication skills. And we're just showing a couple of resources that we found that seem to be very helpful. For example, Jeffers and all published in the MedAir portal, the End of Life Care, a multimodal and comprehensive curriculum for graduating medical students, utilizing experiential learning opportunities. Now, as you can see, this is really a very comprehensive curriculum. We're only showing you the main areas that they address, but this is geared more towards medical students and the ones that are feeling the blunt of taking care of patients, even being deployed when they're from different specialties right now, are our residents and fellows and even our faculty. Another resource came from the American Medical Association magazine, the ethics part, and Smith was talking about just 4 touchstones of end-of-life conversation, very general, about establishing rapport. So if we can see that he's talking about not only the technical aspects of end-of-life conversation, but about the skills that we need to develop, that establishing rapport, building relationships, talking about standards of care that they have to be aware of and clear, perform a life review, which it's part of exploring the values of the patient and the family, and help the patient settle things with loved ones, which includes being able to say goodbye, being able to say I love you in a way that is respectful and meaningful for the patient and their families. But what we are proposing here goes a little bit beyond the resources that we have found. We are talking about creating a consolidated resource that might put together all these different, resources that we have found to teach and empower residents to have conversations and facilitate these difficult situations with comfort and compassion. This might help alleviate potential trauma and moral distress that we are witnessing that might come from some ineffective or unskilled communication. And it needs to be based on innovative, culturally competent, and evidence-based comprehensive approach. So we're proposing a multifaceted, multidisciplinary. As you can see in our team, we have 2 physicians, 1 in palliative care, one in surgery, and 2 LPCs, licensed professional counselors that are the behavioral health consultants for GME at UT Health San Antonio. So this is a multidisciplinary team, and we're trying to consolidate the pieces of the puzzles and going beyond just basic communication skills. What we are proposing is to address those basic communication skills and information sharing, patient and family-centered goals of care, how to create these goals of care, end-of-life symptom management, caring for the imminently dying, how to develop cultural awareness, and another very important part of this, how to develop self-care strategies for the providers, for the doctors and the residents, fellows, faculty, to avoid moral injury and burnout. So in summary, what we're trying to propose here is, let's train residents and fellows and faculty beyond palliative care to have this very difficult conversation. We're witnessing right now in real time the consequences of people, including trainees and faculty, not having the resources and skill sets to deal with these very high volume, very high intensity situations. So, and now with the COVID pandemic, more than ever before, the pre-existing problems such as social determinants of health and other issues in our health system are being compounded by the pandemic. And we're losing healthcare professionals. And we're hoping that by offering more appropriate training, this might mitigate the situation by combating burnout and distress. If you want to read more about these different resources that we have mentioned before, here are our references, and please don't hesitate to contact us to discuss a little further what our strategy and our project is to create one comprehensive resource for our residents, fellow faculty, and trainees to address the difficulties and develop the skills to have these end-of-life conversations and crisis situation conversations. Thank you, Dr. Prasad. Do you have anything else to add?
Feel free to reach out to us, and we would be presenting more on the data and how we would be sharing our resources to across schools. Thank you, Dr. Dyurich.